move ahead with the research article review session. And for that, I would invite Dr. Prasanna Kumar, and he is the episode expert for the session today. And along with that, I'll also invite Dr. Yash Patel to moderate the article session as well as introduce and support Dr. Prasanna Kumar.
Good morning, everyone. And we are mentored by Dr. Prasanna Kumar, and it is indeed pleasure that he is along with ourselves. And this is an official introduction to Dr. Prasanna Kumar, that is a consultant endocrinologist from Center of Diabetes and Endocrine Care, Bengaluru, and was past president of RSSDI, Indian Thyroid Society, and Endocrine Society of India, who is who is in our faculty body of Swasthya also, and he had mentored all of us around and personally me to many aspects. And it is indeed pleasure to be with him to support him in the moderation of this clinical research papers session of ourselves on today. So to start with our first talk, Dr. Prasanna Kumar, can we proceed with the article? So yes, to start with our first talk, we have endocrinologist from Bhopal, Dr. Jaideep Khare. Good morning, Dr. Jaideep Khare. You can start your sharing. And it is indeed pleasure to invite you to be part of this monthly metabolic disease review episode of May. Your article is from Diabetes Care of April 2020, as these are the recent published articles, and that is on that is on rapid change in serum testosterone.
Thank you, Dr. Yash, for inviting me for this prestigious kind of conference, and my regards to Prasanna sir. And we have I have personally met him once during the ASICON in Trivandrum. So good morning all. So my today's topic is rapid changes in serum testosterone in men with newly diagnosed type 2 diabetes with intensive insulin metformin. Whether on the intensive insulin care or the metformin. So this was article which was published in 2021 in Diabetes Care in April month, and was the authors were HUI and Ring B, and they have studied. Basically, this article is required because we all know that type 2 diabetes or any metabolic syndrome is associated with any kind of hypogonadism, which may be central or which may be peripheral. And there are studies which shows that there is severe insulin resistance, and it is related inversely with the serum testosterone level. And we all know that for any metabolic disease, whether obesity, plain obesity, or type 2 diabetes, metformin is the drug of choice. Early type 2 diabetes, if not contraindicated. And there are very less studies that those have examined the effect of metformin on the androgen levels in men. So in this, the authors have performed RCT, including 70 men which were newly diagnosed with type 2 diabetes, to investigate the effect of metformin on testosterone levels at the end of 1 month treatment. In this, the patients, as in China, this was a study in China. There, the patients were when diagnosed with type 2 diabetes, they are have to undergo with the treatment with the intensive insulin therapy, so that the blood sugars comes under control within 3 to 5 days, and then only the further treatment is decided. So here, what the authors have done, they have treated all the patients with intensive insulin infusion for 3 to 5 days, so that the blood sugars are under control. And then in one group, they have continued with the insulin only, and another group, metformin with insulin. And then they have looked for the total testosterone levels, sex hormone binding globulin levels, C-peptide levels, weight, HbA1c, lipid profile, and the blood sugars level, fasting, and the postprandials and random. And also monitored the International Index of Erectile Function, questionnaire based at the baseline and at the end of study. And the free testosterone and bioavailable testosterone was calculated. Why this study was done, why they have think of this study. So the background references were that the authors themselves has identified in 2009 in a cross-sectional study that all the patients, those who are on metformin, they are having slightly low testosterone levels, and as the glycemic variability increases, the circulating testosterone levels comes down. So this was published in 2009. This was the trial, this was the cross-sectional study which made them to think this thing. But there were the previous studies by Jadi and Morche which have shown that the sperm motility improves with the metformin use and in the insulin dependent diabetics. And another study in 2011 which was published by the Morgan have published that metformin improved the semen characteristic in the patient those who have oligotetra azithospermic sperms. So the other study which shows that if we have in women those who are obese, those who are suffering from polycystic ovarian disease, if we give them metformin, the testosterone levels comes down. So why does this not happens in the men also? That if we are giving metformin, the testosterone levels should come down. So these were the articles which make them think that we have to think about. Like we know that diabetes is itself a cardiovascular equivalent. So all the drugs which are coming for the diabetes, they should be facing the CVOT trials, because if we are taking a molecule which itself is going to be a risk for the cardiovascular disease, it should not be used. So same way, the metformin is something which is used since very long. We should know that diabetes or metabolic diseases itself is a risk for low testosterone levels in male. So what is the effect? So in this study, they have analyzed that I will say that the normal testosterone levels, if we have to look for in nanomoles per liter, ranges from around 10 to 18 or 10 to 19 nanomoles per liter. So here the patients were already at the baseline, we are having low testosterone levels. On 5th day, when the insulin blood sugars got controlled after intensive insulin control, all the patients, the testosterone levels reached normal around 15. But when the patients were shifted over the metformin, all the patients were just on insulin only. After 1 month, the testosterone levels again declined in the arm with the metformin. Same thing, the free testosterone was calculated, and same way bioavailable testosterone was calculated, and the percentage change in testosterone was seen that there was significant change in the testosterone levels in the metformin arm. So what I think here that yes, poor diabetes can lead to low testosterone levels and lead to male sexual dysfunctions. And if we are adding a molecule which can further lead to reduction in testosterone levels, it should be used cautiously. So this study demonstrated that the effect of metformin on testosterone may be independent of blood glucose levels, as the previous studies by Morje and Jahati has shown that there was significant change in the weight. Maybe the weight change was the parameter which has led to improvement in the sperm quality and the sperm motility. But here in the glucose, the control arm and the placebo arm, the insulin arm only, there was no significant change in the weight before and after therapy. But yes, there was a decrease in testosterone levels, but the IIEF, the International Index for the IAF index does not differ in the two groups. So I will say here that yes, if the testosterone levels was on the lower side, but it was within normal range. That was the reason maybe that there was not significant range. So I want to conclude that this is a very well written article, and here they have concluded that the intensive insulin therapy can increase testosterone levels rapidly because of the good glucose control. And metformin may reduce circulating testosterone levels significantly in 1 month. But long-term effect of metformin treatment on testosterone needs to be further studied, because this is a very short duration study. And we know that the metformin is the first line drug, and it is there in the market since very long, and since 2001, it is a first line molecule. So these are the various references that as the studies, the Chinese studies have shown that we have to monitor B12 levels regularly on the patient, those who are in metformin levels. So do we need to monitor the testosterone levels also regularly in the patients, those who are on metformin? This is a question which we should think of. And if we have, we know that there is low testosterone levels in type 2 diabetics, so we should try to use the molecules which doesn't impair the metformin levels, or like we avoid using metformin when the eGFR of the patient is less than 45. So something when we are starting with the patient, we are start initiating the therapy, we should initiate with the we should get the investigations of the testosterone. If it is on the lower side, we should avoid it. So these are the further things which we should think about. So thank you for patience hearing. And here I will stop my sharing. These were my personal views. If any further comments, I welcome all of you, please.
Wonderfully timely managed. Thank you, and providing the whole inputs in. Me and Dr. Prasanna Kumar and myself were concerned about the article, that how the testosterone and the other things would look after. And we had this interaction for almost 10 minutes and you briefed it in the 6 minutes. I really appreciate it.
Thank you. Thank you.
Yes, Dr. Prasanna Kumar. Yeah.
Thank you, Dr. Jaideep Khare, for
Thank you,
a
sir.
very comprehensive and very concise presentation of the article, plus also as a reviewer your comments. Now, I want to take more time. I told Yash,
Yes.
I don't want to cover 6 articles in 6 hours.
Yes.
I can take 1 article in 3 hours also.
Yes.
Right? Because
That is your
medicine is not,
experience, sir.
medicine is not length and breadth, medicine is also depth. Okay. Now, we can continue to argue about this article 2 hours also, nothing will be there for the time. But let me also try to be concise and brief. When somebody presents an article or when I read the article, first thing I see, where is it coming from? Qing, Ping, Ling, Yu, and all can be from Taiwan also, China also, Singapore. Where is this article from?
This is from the China.
Okay. Why do you look at Chinese article?
Sir, I will say.
Or how do you look at Chinese article or Chinese imports, whatever you call? Let me be very blunt.
So I will say that how they are doing the studies, we don't know how authentic it is. But this article is published in one of the very reputed journals. So we have to look with very great respect for this. But yes, that I have commented that the thing is that metformin is in use since very long. And personally, we have not seen this kind of patients that the testosterone levels are going down, because they have made the recommendation that B12 has to be monitored. Now another recommendation might come after 3 years that testosterone levels has to be recommended. That's why I have commented that the baseline testosterone in the patient was 12 nanomoles per liter, which is normal, because we consider from 9 to 18 is normal. So whether it is 259 or 11, it is not going to affect much. So if 12 is coming back to 12, it is not important for us from my side, because if we have to look for that FE factors doesn't differentiate between two. So what we are looking for, whether the patient is sexually satisfied, whether the patient is able to have progenies, it is not going to affect much, because IIEF factor is good. But just looking for the values, how important it is, I will say it may be important, because if the patient is on the low testosterone levels and then we are starting metformin, it is further going down, may be harmful for the patient. But I would like to have your expert opinion, sir, regarding this.
You said it is from China. You
Yes,
said
sir.
it's a reputed article.
Reputed
I will not
article.
take Chinese article with a pinch of salt,
Yeah.
probably with a bowl of salt. Because you remember, you go to net and then search 38 articles, high impact articles from China has been withdrawn. Why did they do it? Because it was fraud. Okay,
Yes.
it was fraud. So highest number of withdrawal, any JM I'll show you articles, meaning that China has that ability. We want to be number one in everything.
Yeah.
Publish or perish. They say they don't care. I want to publish 1,000. I'll give an example. Anecdotes are important in science. I was a reviewer for RSA journal, and I got a letter from Peking University professor. I don't want to name. Dear Dr. Prasanna Kumar, I know you're in the review board of editorial for this. We have submitted an article for RSA journal. If you can help us in publishing this, we'll be invited to Peking University for a short while for a talk on that. I was shocked in my lifetime, first time I have seen. I sent it to G.R. Sridhar, who was the editor. Be careful with this person. You may also get a such thing. Have you ever done it in your lifetime? This was 10 years back. Because there is so much of pressure, we want to be the largest number of publisher. Does not matter quality. You know, the Chinese are that doesn't matter if somebody is recording, the cheapest and the worst. And yesterday they told me grade 1, grade 2, grade 3. Grade 1 goes to America, grade 2 to Europe, grade 3 come to India, cheapest and the worst. And today they are taking the fake oxygen concentrators, which are not working,
Not
not even delivering 40% of the oxygen. People are dying,
True,
right?
sir.
So
True,
that
sir.
is why be careful. Singapore also may be Chinese, Taiwan also Chinese, but I relate that. Okay, same name may be there from Taiwan or even South Korea. I will replace it. We will come to the first article later on. You may need 2 hours to do the first article. Yes, I told you that article. You have so
Yes.
many gaps. So when I look an article, first thing I see, who is the person? Because there are so many frauds. Suppose
True,
you
sir.
say it is Dr. V. Mohan. Sir, we know Dr. V. Mohan is the best scientist in this country. We say Dr. Yagni, sir, we have all respect because the quality of paper, they say, there is no question about it. No, this one, because first thing is the name, next thing is the institution, third is country, the last thing is journal. Some of the things, I published a paper 0.04 index, okay, that is JIMA, Journal of Indian Medical Association. I don't know, 0.2 or 0.3. Somebody rings up from UK and say, we are making idea of atlas. I saw your type 1 data. I believe this. I don't believe all 3 people are published in India, but your data is correct. Huh? I thought it is 0.4 JIMA. Who will read? See, that is why, see the journal, see the person, see that. When you choose an article, first sentence I want is, what is the knowledge till today, right? Not at the end. What is the knowledge today and why this study was done? The knowledge today is that metformin does not affect testosterone. Now this study shows testosterone, metformin. That's why I'm looking at. Next, what does the title say in this article? What is the title of the article? Read carefully.
I will just.
Yeah. Sometimes you see the title and then see whether it makes relevance to that. Rapid changes in serum testosterone in men with newly diagnosed type 2 diabetes. See, it is only rapid changes. It does not say anything else. We are only looking, if you try to draw conclusion out of it, and that analysis, what is the title, whether the study makes sense to it, and whether the conclusions are drawn are based on scientific or not. For that, we have to go, what is the knowledge? Now they quote something, PCOD women with high testosterone, given metformin, testosterone comes down. Why are you referring a study, women
and
testosterone?
men.
See, totally different. It does not make sense. Somebody with a testosterone so high and somebody with 0.5, 0.8, where are you comparing? PCOD is a different mechanism. Is it hypothalamus, pituitary, whether it is adrenal, ovaries, or everything in the orchestra? PCOD is a waste paper basket. Nobody knows the etiology. Where is the pathology? And is there a single treatment PCOD? No, at all. It's a waste paper basket. And you are trying to bring it here like that. Others themselves have referred to that.
True,
now, let us say we are taking 2 ones. Look at the basic defect. People who had HbA1c above 9%. Okay?
Yes.
That is not what you see everybody. What is the treatment? Intense insulinification. What is it? Pump. Do any one of you follow this? This was a Chinese article 10 years back where 14 days they were on pump. Then they said multiple dose insulin. The intense insulin does not mean pump, does not mean multiple dose. I give 1 dose of basal bolus, 1 month they are off by disposable pen. What is the hurry to bring down blood sugar to within 3 days, 5 days using pump? Neither it is practical nor possible. Are you doing it for a study?
Yes.
Next thing, that's why I'm telling you, it is not length and breadth, depth also in medicine or endocrinology, wherever it is. Now they say, oh, fantastic, C-peptide done, HbA1c done, we have done testosterone total, we have done pre-testosterone, binding up now SMB, this sex hormone binding globulin, we have also done bioalpha. Fine. Suppose you are looking at rapid changes in testosterone. All the endocrinologists knows testosterone has got a 24-hour rhythm. I am not interested in your basal. Even if you take basal, they have not mentioned what time you have to take. You have to take morning 8 o'clock to 9 o'clock empty stomach. You have to take 3 pooled samples. Put it in the same. Has it been described in the methodology?
No.
Not
It is
at
not.
all.
Not at all. Yes.
Right? We have done studies 20 years in rats and human beings on testosterone. What is it you do? Suppose I am the investigator. I want to see rapid change. That's why I said title. What I will do, I'll put a cannula. I don't want to hurt you much. Whether you are admitted in hospital or at home does not matter at all. You can take samples every 1 hour or so and see 24 hours. Why? Because testosterone has a rhythm, and it is maximum building morning 5 o'clock to 9 o'clock and least in the evening 4 o'clock to 7 o'clock. So what we measured, we have done it in macaque monkeys where it is easy. They are caged, put a cannula on the back, otherwise monkey will pull out the cannula. We had a 400 primate lab in Indian Institute of Science under Modgal 20 years back. Nowhere in the world it was there. Impossible anywhere in the world. 400 primate lab. I've seen in Germany, in East Lag lab, they can't afford 10 monkeys also. 400 monkeys, veterinary hospital. So you put a cannula and take the sample every 40 minutes, 1 hour, and then 24 hours area under the curve. Beautiful. See? So suppose you see, you are giving whatever treatment, whether metformin, insulin, any damn thing, I don't care. Then you are not bothered about sugar coming down or whatever it is. Let us say one group, 1 day or 2 days or 3 days, you do the 24-hour area under curve. Compare again your area under curve after 5 days. Just look at it. Because like what you do in cortisol, I'm sure as endocrinologist Jaideep knows.
Yes,
So
yes.
area under the curve, 24 hours cortisol secretion. Hormones is not like something else. It is something like a HbA1c. How much did X produce testosterone in a day? How much did Y produce? That is acute rapid changes, not taking one value here, one value there. And as you said, good. Some of the aspects are good. I don't say the whole thing is trash. Some of the methodologies, they are good. They have spent a lot of money and others. But if I were to ask the rapid changes, where you want only 24 hours, we don't need too long and all. I don't want to wait till the blood sugar comes down, because though blood sugar came down, right, in the insulin group, you see testosterone maintained. So why bother about that?
Yes.
Again, the next thing what I see, methodology, whether method is correct, and results analysis. Then you have to see, most important, any study, we can say fantastic, excellent. What are the limitations of this study? I always want you to put one, what are the limitations of study? 1, 2, 3, 4, 5. The limitations can be done if the aims and objectives are wrong. My own interpretation for those, Ananya said, I'm a student. When you start a study, you have a research question. What is your question? If you don't know what is your question, your whole methodology is wrong. And when there is a research, ask one question, you will get one answer. Is that the end of us? No, sir.
No.
You ask one question, you will get one answer. But if it is a good science, it will post 6 questions like we are posting this question. 1, 2, 3, 4, 5, 6. That means one study will lead to next 6 studies. When you read this article, I think Jaideep will say, I want to do 5 more studies with different methodology, different one, long, what is the long effect and all. You yourself said, diabetes itself sees that testosterone is less. Then, are they of the same age group or not? From the age of 40 till 90, every year 0.1% of testosterone comes down.
True, sir. True, sir.
Do you know all of them are same age group? All of them are 40 years, 45 years, 50 years. If you take 40-year-old, 50-year-old, 60-year-old, definitely it is going to be different, even baseline and all. Whereas if the same person is there, area under the curve 24 hours, that will give me a fantastic idea what it is. Now, we'll go into deeper into this. What are the metformin dose used from day one, Dr. Jaideep?
They have used 1,500, and then they have reduced if the patient was not tolerating.
Is that the way you treat your patient?
No, sir.
Or other way around?
Other way around, sir.
1,500, they will all have vomiting.
Ji, sir. Ji, sir.
Mayor, yes, will start. None of us will start.
True, sir. True, sir.
Any
True,
drug,
sir.
you always start with 500. Some people don't even tolerate 500.
True,
Sometimes
sir.
you start 250.
True,
So it's
sir.
a homeopathic dose. At least 500 mg OD 5 days. No nausea, vomiting. Then 500 mg BD, 500 mg TID. By the time you reach 2000 units, and what you do at that time is, you will take 3 to 4 weeks. And this is the nitty-gritties of starting metformin. If somebody has started 1500, he doesn't know how to start metformin at all. None of us will start with that. You start that 1500 is Voglibos, sure he will have vomiting. That is the worst combination to start 1000 mg BD, 50 mg BD, Voglibos, or even we say Vildagliptin finished. So that is how I'm telling you. Why are you using something which is not used in day-to-day practice? The last thing we have to look at is, whatever we have spent 25 minutes, yes, not it. Not
Yes,
10
yes.
minutes, we have taken 25 minutes, I am not completed. There are others to talk about it. I am not the only one. Don't stop and say 2 minutes, you say. So look at this. What is the practical implication of it? You are talking of guidelines. One paper will never make guidelines. If it is not repeatable, if it cannot be, and this is Chinese population. We don't know. Chinese people never use a razor. Okay, we use every day, twice a day we shave. Don't compare Chinese to Indians to Americans and all that. Unless it is repeated, all population, these data is shown, it will never see the light of the day. What is the clinical importance? Last important thing is, should we check tomorrow onward some young person? So I read this article, beautiful article by Jaideep. Every patient diabetic, when I put metformin 6 months, I'll do testosterone. My God, this is how my professor used to be 30 years back. Yesterday he reads an article, tomorrow he'll start translating.
No, sir.
Never see the light of the day. So what is the practical utility of this article? Why should I read this article? Can I translate it tomorrow? Because what we learned in the dark previously, now in the light Sunday, can it be implicated in Monday morning in practice? Definitely not.
No.
They themselves have said it needs larger studies. It needs long-term one. So they themselves give an idea how to make next 2 papers. Large number of studies, same age group, let us say 40 to 50, 30 patients each group. Then they have got 70 patients, 35 each. Then you have to see long-term studies. Maybe 5 days you see metformin come down. After 3 months, metformin also goes there. Insulin group also may go down. Is it the effect of metformin coming down? Or do you say, is it the effect of insulin that is increasing the testosterone? We don't know. And most important, remember, when you have IAEF 5 and all scoring nonsense, what is the best way to say whether man is performing or not?
Free testosterone.
Huh? No, his wife or girlfriend. He will always say, sir, I'm satisfied. Ask the wife. Wife will say, I'm not satisfied. Then you know what it is. No man will say, I'm unsatisfied. So when we did studies in FSH vaccine trial 20 years back, first time in the world, we involved the wife and said, what is it your satisfaction level? Before the drug, after the drug. Suppose she says his performance is come down. Then do you think IAEF criteria is good? Or this is the good? What exactly you are doing? Are you checking testosterone with erection? Suppose you are doing erection, there is a band. You have to put a penile band. Next day morning, as the erection occurs, the band snips off and then do that. That is not done. The IAEF scoring is not the ultimate. So that is why you see the idea, knowledge, methodology, and then interpretation, comments, criticism. We may criticize like this. Unfortunately, the Chinese man is not there to support himself. It is one way, but still, this is what I personally feel. I want no other's opinion.
Yes, thank you, sir. I totally agree with you because what you told that we have to ask from the partner. So if the partner is persistently saying into kamjori बहुत लगती है, कमजोर हो गए हैं बहुत ज़्यादा, तो indirectly we should understand that she is talking about that thing only because the place until unless it is not a place like first tier city or the advanced population, they will talk in second wave only. सब कमजोरी बहुत लगती, कमजोरी का कुछ कर दीजिए.
That's what we have to open up the forum to talk to them. Yeah, and yeah. They would be intimate to talk about also. Yes. So that's where the article is to keep it in the mindset only, like Dr. Prasanna Kumar also shared. Okay, first is doctor's barrier. When we break those barriers, this is one of those background, and why Asian populations sort of think by the scientific committee is also in that background. And another aspect is we have the larger population, and like what audience we have at present, we can conglomerate these aspects and join the bigger study for the same direction. That is also with the articles taking behind in this forum is in that background also. Yes, and thank you for this critical inputs. We have invited the first authors or the correspondent authors of each of articles by our scientific team, and maybe some of them would be available and maybe defending themselves around to our critics. I really appreciate what scientific team had put the background and what our experts are sharing. Thank you.
Yeah. Thank you. Thank you, yes. Sir. Thank you.
Prasanna sir. So with these inputs, and like you rightly mentioned, can we have the minimal articles, the interaction on the higher note, And maybe I'll just put a question here and then we'll proceed for diet talk, and we'll revert with that. We will take 3 articles on today and the further 3 articles on another.
Next, other thing is, yes, remember, this should not be an academic exercise. Let us say today we have discussed it, okay, in breadth, and others also are free to come. Don't stop anybody. See, everybody comes to a meeting to talk, not just to listen. Let us say Dr. Jaideep has spoken 10 minutes, others I want to talk 30 minutes. That's how discussion occurs. Next thing is, okay, this is an article, whether diabetes, whatever. Then we will put Jaideep, sir, you are the one who have read this article. Let us try to see whether we can do a better study. Now, Jaideep will come back next month and then say, I have written a protocol. Okay, it needs this. We don't want to do insulin pump, blah, 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 and all that. We want to do only, let us say, Rhizodec injection for 1 month and control very fast. Rhizodec plus metformin, without metformin. At the end of 1 month or 2 months, we will do it. We can't do 24 hours Scanla and all that. Now, Jaideep is responsible for writing a protocol. Next, we will put it to 30 people. Now, out of 30, there may be 10 people, and these 10 people are going to say, okay, I am in this study. Yash may say no, Mayur may say no, I may say yes. Who is the first author? Jaideep is the first author because he has written protocol. Now he will take 3 months, not even 1 month. To do this study 1 month, protocol it will take 3 months. Then all of us will have a thing and then say, criticize Jaideep. This is not correct. Title is not correct. And methodology has to be changed. At the end of 3 months, August 15th, we agree. Jaideep, this one is pakka. We have no comments, criticism. Then Jaideep will be the first author. Then all of us agree, I may give 5 Ks, Mayur may give 4 Ks, Yash may give something else, Ananya also may give 5 Ks. At the end of 6 months, we have produced 1 paper. And who will be the second author? Whoever gives the maximum patients will be second author. Maybe Yash. Third author will be less than that. As a group, because all of us are good in reviewing, talking and all that. But are we going to action? Why can't we, after doing that, take? Let us say we have reviewed only 3 articles. Out of 3, 1 or 2% will come back, sir, I will write a different protocol. Aim is clear, objective is clear. Because of this group, if somebody is most educated, JD, he has not only read this article, previous 15 articles, right? You have never read so much in your lifetime about metformin and testosterone, whatever is today.
True, sir.
So,
True,
because of that, you will be able to commit it a protocol. And out of 35 people say, sir, we agree. This is the brainstorming group, separate session, not here. And we say, and we start, we register a clinical trial, okay? And then we publish it. Then Yash will feel, Mayur and Yash said, sir, we started as a simple journal, sir. It became a research team. Suppose we are not sufficient. Mayur will ask a professor of biochemistry to join. And Yash will say, sir, none of you have statistics. I'll ask a biostatistician in Ahmedabad to join this group. We may say, I want a geneticist to add this group. So this research team, what is wrong with our research is, I am Prasanna Kumar. I don't trust any 35 of you. I write the idea. It is my protocol. I collect the data. I publish it. Ultimately, I will not be able to publish one. It should be like a assembly line. Yeah. Jaideep is only good in making the protocol. Yash is good in collecting people. I am good in statistics. Somebody says, none of you know how to write paper. I will see it gets published in Diabetes Care. So each one of us have a different, what you call advantage or mechanism where we bring all our knowledge and skills, then 10 of us. Otherwise, if I try to do everything in my lifetime, I am not have more than 100 papers. I wish this journal club will be like that, not length and breadth. 30 minutes over, yes. Only 1 article.
Sir, this is the right motive. This is the right motive behind it. And
that's why I told you, I'm sorry, in one of the institution, क्या है पहला आर्टिकल बेकार है चलो अब दूसरा आर्टिकल क्या इसमें कुछ नहीं मैं बता दूंगा तीसरा आर्टिकल 16 articles they read in one DM endocrinology. I don't want to say premier institute in this country. I said this is not the way to do that. Where are you from, Dr. Jaideep? DM?
I have done my DNB from Hyderabad, sir. Krishna Institute of Medical Sciences with Bipin, sir.
Bipin sir.
Yeah.
So that is what I said. Where I was in R&D Institute, not 2 articles, 1 myself, 1 Ambrish. That's all 1.5 hours. At the end of it, we go back. I think I did not do properly work of it. Because these are all the questions. And Ahuja and all, kya bhai? ये तो नर्स कर सकती है, ये तुम, we thought boss will pat on our back, ये तो नर्स कर सकती है, तुम्हारा रोल क्या है, यहाँ खून लेना, वहां देना स्टैटिस्टिक्स, ये तो डीएम का काम नहीं है. So at the end we used to get depressed. So that is how I want the quality more important, even if you discuss too, because it's a learning curve for everybody. As I told her, Ananya, you are not the student. We are all students learning from each other. I want to go back. I got so much from Dr. Kulkarni's talk about this. Half of it I don't know, right? I would have never have read this article in depth. Thanks to Jaideep, who has read into article, answered, comment, criticism. It is not number game. It is the quality of discussion we have. Even NEJM article I see, I saw with Bhandarkar, he used to keep NEJM. Mark this, sir, what is this? Spelling mistake, grammar mistake. Bhandarkar used to make spelling mistakes and all that in that. I mean, such a wonderful man, such an astute clinician. I had to learn 1 month from him how to read an article, how to comment, how to criticize. 100% practical one. Right? We have read the Santoshkar Bhandarkar pharmacology. And the most astute man, when he comes to conference, he will not have coffee, tea, lunch. Sir, why is it? No, this is given by pharma. I don't want. I have my dabba in my car. I will have it. When I invited for a meeting, I won't come. I said, I'll give the ticket. No, where will you get the ticket? You get that money from pharma. I don't want. How many people we have today? Carry on. Sorry.
Yes, yes.
So, Dr. Prasanna Kumar, sorry. Yes, Dr. Prasanna Kumar, you have rightly mentioned an excellent suggestion. We all of us, if agree, we ask you to take the lead. We'll initiate right from today. We can initiate the activities, and you can take the lead. Our team will help you in managing all the show. The research lead and like-minded people here, all probably around 40 people. These all are people interested in research. Yes. So you take the lead. And take the initiative, will help you out.
We are there.
We can even have 1 day training. What is research? Why should we research? What is the methodology? Okay. And 1 day we'll have GCP. I don't know how many of you are trained on GCP. I had a GCP training last month. Mayur, I'm 68. 6 hours, 3 Tuesdays, 18 hours. Then I had 180 to 200. No, sorry. 400 to 500 slides to review. After that, 900 pages, GCP ICH guidelines, Indian guidelines, CITSCO guidelines, and all that. Then I had an examination. I woke up Friday morning, 6 o'clock, 30 minutes I took examination. There were 20 questions. If I get less than 70, I'll get a certificate of attendance. If I get more than 70, I'll get a completion certificate. I got 17 out of 20 questions. And I got a certificate of completion. I said, God, I have passed DM. If I fail this examination, what a shame. So after doing 30 years, 300 research, I had to take examination. I mean, there is nothing wrong in it, GCP. Yeah. So let us do one GCP. For us, we are at the sunset stars. There are rising stars like Ananya, right? So it is for these rising stars, research methodology. We don't want RSS day 500 people doing. Your own small 40 people, right? And we'll take a biostatistician in Ahmedabad, okay? We can take somebody who is a ethical committee members informed consent. Because this is what you should teach, which is not taught in medical college, MBBS, MD, DM also.
That's true.
So have this, at least out of 40 people, 3 of them come back to Mayur and sir, this is what I attended. After 10 years, I have 50 papers. That is done your job. It should not be just an academic exercise. Reviewing, commenting, criticizing to show how much knowledge I have. We want knowledge to be converted into action.
Yes.